disadvantage, though, is that it's not suitable for pregnant women, for those with endocarditis. It should be avoided in patients with burns greater than 20% of the body surface area, and also patients with kidney problem, creatinine clearance less than 30 mL per minute. Gentamicin is not usually recommended for them. Now, pharmacokinetics of gentamicin is that it's highly lipohydrophilic. It's not distributed in the adipose tissue. Gentamicin, like other aminoglycosides, are cleared by the kidney, and it's therefore important that renal function is assessed before treatment. And it's also important to ensure an accurate renal function value to reduce the risk for toxicity. So anytime we want to dose gentamicin, it's very, very important we check the serum creatinine, calculate the creatinine clearance, because any value less than, after calculating the creatinine clearance, any value less than 30 mL per minute is responsible for nephrotoxicity and ototoxicity. Now, for example, how to calculate gentamicin. Majority of patients prescribed gentamicin, we have to use the ideal body weight for calculation. And the ideal body weights have different formula for both male and female. For male is 50 plus 2.3 times the number of inches above 5 feet in height, while for female is 45.4 plus, in brackets of 2.3 times the number of inches above 5 feet in height. Now, a typical example is AB was prescribed gentamicin to treat her PID. Her height was 5 feet 6 inches and she weighs 67. Now calculate her appropriate ideal body weight. The solution from the formula is 4.5 into brackets 2.3 times the number of inches above 5 feet. Now, for this particular patient, she was 6 feet above 5 feet. So if you plug in the values, we have 4.5.4 plus 2.3 times 6 inches above 5 feet, and that will give us 59.2. Now her body weight was 67, but her ideal body weight should be 59.2. So in calculating the creatinine clearance, we're not going to use, or sometimes some people use 69, which is the actual body weight, but it's advisable you use the ideal body weight for calculating creatinine clearance. And for a man, example, it's AB is a 52-year-old man prescribed gentamicin to treat his urinary tract infection. His height was 6 feet 1 inch and he weighs 87 kg. Calculating the ideal body weight. Now plugging in the formula for the male is 50 plus 2.3 times the number of inches above 5 feet. Now for this particular patient, he was 1 feet 1 inches above 5 feet. And we know that 1 feet is equal to 12 inch. 1 feet is equal to 12 inch plus the extra 1 inch, that's 13 inch. So when we plug in the value, that will be 50 plus 2.3 times 13. And that will give an average of 79.9 kg. So when we're calculating the ideal body weight, instead of using 87, we're going to use 79.9 kg. And calculating the creatinine clearance, we use the Cockcroft and Galt formula, which is 140 minus age times the ideal body weight divided by serum creatinine times 72. Now, this particular formula, if you were a female, the male formula times 0.85 will be used to calculate for the female creatinine clearance. Now, this is another formula for calculating Cockcroft and Galt. In this particular one, they use the body surface area also for calculating creatinine clearance. There's also another formula for calculating creatinine clearance. Basically, they all have the same formula. From females, we just multiply 140 minus 8 times the body weight over 72 times serum creatinine times 0.85 if it were for a female. So why we use creatinine clearance is for drug dosing adjustment for underweight patients, to calculate the actual body weight for obese patients, and when we also use the adjusted body weight to calculate creatinine clearance. There's also another formula for calculating, it's basically the same formula. Some use body surface area, while some formula don't use body surface area. Now, in calculating creatinine clearance, after calculating the creatinine clearance, dosing for gentamicin, we usually use a couple of nomogram. Example is the Hartford nomogram. Now, if perchance you calculate after giving a patient gentamicin, and you calculate maybe after, say, 10 hours, you check the concentration of gentamicin. If the concentration of gentamicin after 10 hours is 6, that means you're going to dose the gentamicin every 36 hours. Perchance the concentration of gentamicin is 6, but you check the concentration of gentamicin at 7 hours. That means you're going to dose the patient every 24 hours. As the concentration increases and the time increases, using the Hartford nomogram, you'll know how to dose the gentamicin. Either you give it 24 hours or 36 hours or 48 hours. Now, the Hartford nomogram was based on the result of an American study where patients received 7 milligrams per kg of gentamicin, while the Urban Craig nomogram uses 5 milligrams per kg. Now, they will usually use 5 milligrams per kg, run the concentration of gentamicin, and based on the concentration of the trough concentration of gentamicin, will enable a pharmacist to calculate the next dosage, how frequent you should dose gentamicin, and what milligram you should dose gentamicin because of the nephrotoxicity and the ototoxicity. So the first dose of gentamicin administered at 7 milligrams per kg. If the level is taken should be taken between anytime between 6 to 14 hours after the first dose. And if you take it between 6 to 14 hours, you plug it into the Hartford nomogram. That will tell you how frequently you should dose gentamicin, either 24 hours, 36 hours, or 48 hours. Now, using the Hartford nomogram, if after 9 hours a patient's serum creatinine was 4 milligrams, then they should receive a dose every 24 hours. Now, going back, if the level was 4 milligrams, they should receive the dose every 24 hours. Now, if you go back and we check, if it's 4 milligrams, if you take that down, that means you should dose it, it's within the 24 hours range, so you should dose gentamicin. If it goes to the, if you take it at 10 hours and the level is still 6 milligrams, you should dose it 36 milligrams, and so on and so forth. That's the benefit of using the Hartford nomogram, the Urban Craig nomogram. Now, the drawback of using the Hartford nomogram is that if concentration of gentamicin fall above 84-hour line, the Hartford nomogram may not be appropriate dosing regimen to use. Now we have to use the individualized pharmacokinetic dosing. If gentamicin is to be continued regardless, the dosage should not be administered until the gentamicin blood level falls below 2 milligrams per liter. So if a patient is given gentamicin and after 24 hours, the level is still not below 2 milligrams, you should still wait and check again until the level is below 2 milligrams per liter. If the trough concentration level is not below 2 milligrams per liter, that will increase the patient's chances of having nephrotoxicity and ototoxicity. If renal function remains constant, gentamicin levels should be monitored twice weekly and dosage adjusted accordingly. And this is also an example of the Hartford nomogram. Now, some studies have already calculated the standardized regimen for creatinine clearance and dosage of gentamicin. Now, if you calculate the creatinine clearance and it's below 30 mils per minute, some still recommend that you should reduce the dosing of gentamicin to 2.0 milligrams per kg for body weight. If the creatinine clearance is between 30 to 50 mils per minute, you should give a dosing of gentamicin to 2.5 milligrams per kg. Between 50 to 80, 3.25, and greater than 80 mils per minute, you should dose gentamicin as 4 milligrams per kg. Now, I just want to plug in a particular case study where, still the same case study where AB is a 52-year-old man prescribed gentamicin to treat his upper urinary tract infection. His height was 6 feet 1 inch and his weight 87 kg. Now, after calculating we've already calculated the ideal body weight to be 79.9, but this patient's serum creatinine was 1.4 milligrams per kg. Now, that gives a creatinine clearance of 69.7. Now, going back, anything within 50 to 60, you're supposed to dose gentamicin as 3.2 milligrams per kg body weight for the patient. Now we have different ways of dosing. Now this particular one is an NHS dosing for gentamicin. Now if we go back and take the patient's creatinine clearance as 69.7 and the patient's age is 52, and patient age is 52, that should be the second column, that's between 50 to 59. Now the creatinine clearance was 69.7 mils per minute. Now for to look for that, that's greater than 60. So that means that the patient should receive the gentamicin dosing of 280 milligram every 12 hourly. Now, even with giving the patient 280 milligram every 12 hourly, you should still monitor the serum creatinine level, calculate the creatinine clearance, if the and also gentamicin trough level. If after 24 hours the gentamicin trough level has still not fallen below 2 milligram per liter, you should still wait until the level of gentamicin fall below 2 milligram per liter before giving the next dose. So the appropriate dosing for gentamicin based on age, weight, and creatinine clearance is 280 milligram per liter daily. And like I said, the advantage of giving daily dosing is that it reduces the chances of patient having nephrotoxicity and ototoxicity, which is the two major important side effects for gentamicin. And based on the other formula, where they use 3.25 milligram per kg, dosage for gentamicin is 260 milligram per daily, 260 milligram daily. Gentamicin is an aminoglycoside antibiotic of choice in Nigeria and the UK. It has a very narrow therapeutic index. Underdosing results in inefficiency, while overdosing is characterized by nephrotoxicity and ototoxicity. To improve patient safety and efficacy, clinical pharmacists in hospitals should be involved in protocol for prescription of gentamicin, which may vary in complexity and approach. And also an antimicrobial stewardship program should be instituted in our hospitals. Thank you. That's all.
Well done, Pharmacist. And you? Okay.
Sorry.
Like Pharmacist Akebelo. Hello, Pharmacist Akebelo. Your hand is raised up. We want to thank you, Pharmacist Aliu, for the good presentation. Please, can you stop sharing your slides?
Okay.
We want to appreciate you for the good job done. We don't know if there are any questions from anybody. Question and answer time from anybody. Can you please raise your hand or maybe just include it in the chat box? Hello. Hello, question from anybody?
Dr. Williams is putting her hands up.
Okay. Hello, Pharmacist Williams, please go ahead.
I want to appreciate Pharmacist Aliu for that presentation. It's full of a lot of calculations. And, it will take another, maybe when the recordings are shared, to take careful listening to follow up with the calculations. It's an area where we can actually make our impact felt in the hospital. Now we're talking about pharmacist interventions in the hospital. Once it is appreciated that the pharmacist has a key role to play, even in the prescription, intervention is instituted and we're able to avoid drug therapy problems, then will become more relevant in the healthcare delivery system. So it's a very good timely presentation. Since the turnout of participants only 8, I would suggest if we reach out to other CPAN states, so we can have another presentation in a larger house. It's a very topical area. Like I suggested to pharmacists to put earlier on, there's a means of increasing the population by ensuring that we don't have clash of presentation between states to be good. Thank you so much.
Thank you, Pharmacist Dr. Williams. We appreciate you for that contribution. I don't know if there's any other question. From the chat box, we have Pharmacist Lawal. Nice presentation, well done from Leila. From Dr. Ike Bello, also saying that the presentation is insightful and very educative. We appreciate the speaker. We appreciate everyone for joining us. You're welcome, Pharmacist Edaki Sioma. So, are there any more questions? This presentation
Yes, there's one question in the chat.
From Pharmacist Kolawole. The question is, how many days would a patient take the 280 milligram for urinary tract infection? The injection. She's asking, how many days would the patient take it, be given? So, Pharmacist Leila.
Okay, one, it depends on the bacterial. If it's the methicillin resistant, the MRSA, is usually going to be longer time, 10 days at the minimum. If it's E. coli, for antibiotics, 5 days. So it depends on the causative, depends on the bacterial that is in the urinary tract. If it's the very resistant MRSA, it's usually a long time, 10 days, and it's not just going to be only gentamicin. It has to be with gentamicin and the beta-lactam antibiotics, or gentamicin and a cephalosporin. So it depends on the bacterial. So if it's not too, if it's a mild bacterial, you can say 5 days. But if it's the resistant one, you can move up to 10 days in combination with other antibiotics like beta-lactam antibiotics and the quinolones.
Okay. Mrs. Kolawole, I hope you are okay with the answer. So, Mrs. Dr. Williams, your hand is raised up.
Yes. What is the advantage of the extended release over the traditional gentamicin?
Yes. Like I said, the daily dosing has...
Sorry, can you just take the questions so you answer once?
Okay.
The second question is, you did mention that the likelihood of abuse is there leading to resistance. Would you recommend microbial culture and sensitivity test, especially in view of the antibiotic stewardship, before the recommendation of or the prescription of gentamicin? And if there are resistant cases, what is the alternative antibiotic that could be used?
Okay. Okay, for the first question, sorry, Strike has decreased my assimilating capacity. The first question was...
Sorry, let me take that again.
Okay.
The advantage of the
advantage of extended release over extended daily dosing over traditional one. Now, like I said, the traditional daily dosing has the potential of causing ototoxicity and nephrotoxicity. Now, there's also frequency of dosing. The frequency of dosing is also there, but the major thing is the chances of nephrotoxicity and ototoxicity. Now, they found out that giving single daily dosing, giving a single daily dosing regimen for gentamicin reduces the chance for ototoxicity because it's given 24 hours. So there's a chance, it's giving the chance for the kidney to start removing the drug from the system until the gentamicin level falls down to 2 milligram per liter. Now, if you give daily, if you give frequently, the chances for nephrotoxicity and ototoxicity is also there. Means that the gentamicin level may not have fallen down to 2 milligram per liter before you dose the second one and before you dose the third one. So that will increase the chance of patient having nephrotoxicity and ototoxicity side effects. But for once daily dosing, you give, even with the high, they found out that with the high concentration of gentamicin, it did not result in nephrotoxicity and ototoxicity. With all the studies that have been done with daily dosing for gentamicin, did not result in the chances of the chances of ototoxicity and nephrotoxicity is much more reduced as compared to the traditional dosing for gentamicin. I hope I've answered that question.
Yes.
Now, for the second question, yes, there must be, there must be culture. You must culture your organism. Now, sometimes when the patient comes in, you start giving an antibiotics, you send for culture. Then when the culture comes in and the sensitivity test comes in, then switch to the appropriate regimen for appropriate antibiotics. So it's very, very important that we do microbial culture and sensitivity so that we know which actual medication is appropriate for this particular patient. But still, when the patient comes in, they will have to start with an antibiotic, especially when it's probably sepsis or some serious infection. They'll have to start with an antibiotics before they send for the culture and sensitivity, look at which one is more sensitive to the organism, then you switch to that particular antimicrobial agent. That's for the second question. And for the third question, please remind me again.
Just 2 questions.
Okay, just 2 questions, yeah?
From Dr. Williams.
Yes, yeah, just to, but there's a rider to that.
Okay.
In view of the delicate nature of sepsis, rather than doing empirical prescribing, a new drug has been discovered for case of sepsis.
Okay.
The cephalosporins are quite sensitive. They are quite useful. But in case of chronic heart failure, Astrenum is recommended.
Okay.
Because it's very sensitive to, or selectively sensitive to, gram-negative organisms. Okay. So especially for sepsis, that is quite delicate. And we know the issue of resistance. Why going for gentamicin? In view, especially, or cases of the likelihood of ototoxicity and nephrotoxicity.
Okay.
I don't know whether the question is clear.
Yes. Now, for that particular drug, is it readily available in Nigeria? First question. Because it doesn't, if somebody comes with sepsis and you're looking for a drug that, 1, may be too expensive for the common man, 2, is not readily available, and gentamicin is, very cheap, very available, and very effective also. So if it's available in the hospital, yes, you can go for it. But for the common man that may not have enough money to purchase some of these medications, and you have an alternative medication that is cheap and effective, then we'll go for it. Now, like I said, you have to calculate the creatinine clearance. You have to calculate the serum creatinine for this patient, calculate the creatinine clearance to see if the patient can take this drug or not. Any creatinine clearance, yes, below 30 mils per minute, you should not give gentamicin to that particular patient. Then you can be looking at this particular alternative that you have. Like I said, they did a study in the medical ward, they look at the medications, the drugs commonly prescribed at emergency level. And for gentamicin, it was 11.8%. It was 11.8%. I think the cephalosporins took a higher chunk of the first line of antibiotics prescribed. Cephalosporins, the cephalosporins, the quinolones, quinolones. Then gentamicin was like, then the penicillins also. Gentamicin was like the fourth line. That's why it came up as 11.8% in one particular study. Yeah, so the first line is usually cell wall synthesis inhibitors, the quinolones, the cephalosporins. Then the fourth one was gentamicin in the particular study that was done. So yes, gentamicin is not used alone for treatment of infection. It's usually used. It has a synergistic effect, especially with the with cephalosporins and with penicillins. It's usually not used alone. But once it is used, you should, as pharmacists, calculate the serum creatinine to make sure that this particular drug is appropriate for this particular patient. If it's not appropriate, it can lead to kidney failure. It can lead to acute kidney failure. It can long-term effect chronic kidney failure for the patient. That's why it's a drug that should be therapeutically monitored in patients.
Okay. Pharmacist Dr. Williams, your hand is raised up.
Yeah, what really gives me concern is the time lag between requests for laboratory investigations and result release. If you are to ask for, if you are to calculate creatinine clearance, you need serum creatinine from your urinalysis, your full blood count, your creatinine value. And usually results are not released on time. So how do we go about solving this problem, the time lag, so that the patient can be placed on the right antibiotic, or let me say the right cheap antibiotic empirically? Dr. Ike is here.
Yeah. I think for UITH, I think it's EU creatinine I think Dr. Ike can shed more light, but EU creatinine don't usually take long. I don't know. I think so. Dr. Ike below.
Sorry, is on motion, is on.
Oh, okay.
Yes, so
okay.
He might not be able to.
It's for UITH, it's usually standard. When a patient come in, they just withdraw blood, EU creatinine, because they want to check the potassium level. The potassium level is too high, that it's a problem. So most of the time, I don't know if now, most of the time, that's the first thing they usually do, especially for UITH. They ask for EU creatinine. And sometimes the doctor will have to write urgent, means that within a couple of hours, they usually will get the results. I think so. Because during our rounds, I've seen where when checking the patient folder, you see the report for most of these EU creatinine, they may put urgent, and within a couple of hours, they will have it, or at the maximum by the following day. Now, if you start gentamicin and you get the serum creatinine by the following day, and you say that, oh, the level is too high, or the creatinine clearance is low, then you advise the physician to either withdraw the drug or reduce the dosage of gentamicin to its barest minimum. I think the best will be withdraw.
I think this is where we also come in as pharmacists. For our work to be effective as a team, the pharmacist in charge, that's why I called Dr. Ike earlier on, they should ensure that when laboratory requests are made, results are available for them to function properly as clinical pharmacists. Thank you.
I think Dr. Ike Bill is asking a question here.
He's asking a question, yes. From the chat box, he said part of the side effects of gentamicin is ototoxicity. How do we prevent that, especially with gentamicin 280 milligram in treatment of sepsis?
Now, even at 280 milligram, it's like I said, is the trough concentration. When you give a particular patient 280 milligram, then after 7 or say 24 hours, the trough concentration is still not below 2 milligram per liter, one, either you wait until the level reduced to less than 280 milligrams. That means you have to recalculate. So for the first few days of dosing gentamicin, you have to make sure that, one, as you're giving gentamicin, you continue to calculate, check the serum creatinine to make sure that it doesn't reduce. There's no nephrotoxicity. Now you check the trough concentration. If it's less than 2 milligrams, then you can dose. Giving a patient 280 milligrams start is not the one responsible for the ototoxicity and nephrotoxicity. But after 12 hours, it should have reduced. Sorry, after 24 hours, the level of gentamicin should have reduced to less than 2 milligrams per liter. It is that if it's the trough concentration is still above 2 milligrams per liter, is the one responsible, is that concentration that is responsible for nephro and ototoxicity. I don't know if that is clear. So 280 milligrams start is not the problem. The problem is when you check it 24 hours later and the value has still not dropped. If the value has not dropped, you should not give until the level has dropped, and then you recalculate. Then that means you have to reduce the dosage of use the creatinine clearance to recalculate the dosage of gentamicin. And sometimes if you use the patient's actual body weight, now that's why you have the actual body weight, the ideal body weight, and the adjusted body weight. Now, if you use the actual body weight, it might give you a high milligram for gentamicin. You have to use the ideal body weight, which is usually lower than the actual body weight, to calculate the dosage of gentamicin. Sometimes if you use the actual body weight, you might overdose. So you use the ideal body weight to calculate, and you make sure that the gentamicin level has reduced to 2 milligrams per liter by the following day. If not, you cannot dose gentamicin. That's why TDM for gentamicin, checking the therapeutic drug monitoring for gentamicin is necessary. Calculating the creatinine clearance is necessary to avoid drug therapy problem of gentamicin. I don't know if that is clear.
Yes. Thank you so much, Mrs. Aliu. I want to really appreciate everyone. I just as
my hand is up. Yeah. Let me just say yes.
Okay, please, ma. Go ahead.
I know that this issue is very topical. I would appreciate a situation where our clinical pharmacists in the hospital are here in a very high population, because we have issues that have topical importance that we can really say we are relevant in as clinical pharmacists theoretically. But when the environment is not enabling, then we are handicapped. Yes, we need to calculate this creatinine clearance, but we have to, for us to do therapeutic drug monitoring, every hand should be on deck. It will not be only the pharmacist, the laboratory scientist must be ready to cooperate with us. The physician must be ready to cooperate with us. The results must be ready, so that it's a teamwork. It's not a case of it's my patient, your patient. So I don't know, Dr. Ike, please carry this message to the clinical pharmacists in the hospital. If this presentation can be redone and we think out what is the way forward, because it will really make us very, very relevant in the hospital. Thank you.
Thank you, ma. I was just going to say part of what you just said now. Like the hospital pharmacists, they really need to be aware of this. It's so common, we see prescriptions, like in my place of practice, we see prescriptions for injection gentamicin 280 milligram, or rather 160 milligram, 3 days, for 3 days, you know. Though we don't calculate the clearance and all that, but you know, I feel this presentation, once it's redone again, maybe on the Kwara State platform or Harpian platform, not just CPAM, so that the enlightenment the awareness can go around everybody. And then this issue of a teamwork, it will really help us, and having good labs to help us
Indeed.
with all these values. It's really go a long way because of the side effects of gentamicin, because we realize that it's really causing lots of sepsis, and which people are not even aware of, even the doctors.
Yeah.
Yes.
Yeah.
So as clinical pharmacists, really help us showcase it well. Thank you very much. Francis Ake Bello, are you with us now? Yes. You're still driving?
Can you go ahead and head a meeting?
Okay, okay.
Yeah, I'm with you. Very interesting. By God's grace, we find another forum to represent this very important presentation.
Okay.
It's a very good one, and I commend Dr. Lola and Dr. Mrs. William for their support and great contribution. We should not be discouraged with the low level of attendance. We will continue. It's the quality, not the quantity.
Yes.
Thank you.
Okay, thank you. It's just saying that we should not be discouraged with the number of participants that we have. It's not in quantity, but the quality of the presentation. So once again, I appreciate the speaker from Mrs. Ali Laila. We appreciate you for the good job on. I know some other time we're going to call on you again to give the presentation. We really appreciate everyone, Francis, Dr. Williams, Francis Soriatio. I don't know who is using the iPhone. Your name is not being displayed. Mrs. Kolawole had to leave. But we thank everyone. We appreciate you all. So we just close now with a closing prayer. Francis, Dr. Williams, can you give us a closing prayer?
My dear, please. Let someone
Okay, let me just give it. In Jesus' name, Father, I want to thank you for this presentation. We appreciate you. Thank you for the participants. Thank you for the speaker. Thank you for the topic. We pray, oh Lord, that you help us once again to be good clinical pharmacists and then to be able to help our patients, and not our patients alone, the patient, the team of patients, that will help us, oh Lord, even to give better quality pharmaceutical care to our patients in Jesus' name. We thank you for everything. In Jesus' name we have prayed. Amen. So we thank everyone for participating. Sorry, the CPAN, there are 8 CPAN states meeting holding now. So, like suggestions that have been made, will tell Famzilake Bello, is a national executive of the CPAN National. So you will tell them, maybe so that we can present once again, maybe on the national forum. Thank you, everyone. God bless you. Wishing everyone a happy night rest.
Thank you.
I will also suggest, if it is possible, to present it at their clinical meetings,